All right, everyone. So this is the second part to um, the overall how do we conduct a psychiatric interview. And I just wanted to make sure to do this as well because I think it's something that's kind of overlooked by medical students, but it's still an important part of the history taking that we should be doing in the background, as well as something that we're going to have to include in our SOAP notes as well. Many students get nervous about this. I also had a trouble at the first couple times doing this because I wanted to make sure I included all the right pertinent information and also understanding what each of these meant and why we were writing what we were writing. So this is the MSE. Basically, in psychiatry, because there's not really any physical findings or there aren't really any lab values, we really have to find some way to get the objective findings that we're looking for. For example, we use the MSE. So essentially what this is when we're interviewing the patient, these are some objective findings that we should look for as well. When we are talking to the patient and kind of getting an idea of a couple of things about the patient, which might be contradictory sometimes to their subjective, and overall it gives a great clinical picture on what we should do next with the patient. So this is a document that I got from someone else. I forgot exactly where, but I would strongly recommend looking up MSE Got Words or kind of copying this down, because I would have this document open on my phone or printed out. And basically, once I knew what all this meant, I would plug and chuck all this in, and it would give a better idea of our objective findings about the patient. So first things first, appearance. So why does appearance matter? It gives a good context on what the patient looks like, obviously, to anyone else who's going to be reading the notes later. But it also gives an idea of what might be going on with the patient. For example, grooming is a huge thing. If the patient is uncombed hair, disheveled, unkept, unhygienic, then probably could possibly lead to an indication that this patient isn't taking care of themselves, possibly due to their mental illness, acute psychosis, ongoing psychosis, whatever it might be. And then we can also make sure to look at their gait and motor and posture as well. I'm not going to go through everything too much because some of this is pretty standard just when describing someone. I really want to go through why we're talking about what we're talking about, and hopefully this video will be shorter than the nearly hour-long one we had last time. The next one was behavior. So behavior is really important because, again, for any clinician that's going to see them later, it could be important to see how their behavior is. We can also see day by day, if they're on an inpatient hold, how their behavior has improved given, the mood stabilizers that they might be on, or their experience in the milieu or in the inpatient setting. Has their behavior improved objectively that we can distinguish, right? So seeing if they're resistant, hostile, angry, defiant. For example, I think it was a 57-year-old Caucasian male that came in our previous video. We can say that he might have been resistant to the treatment early on because he was saying, I just need to go home, I have work, and I have to take care of our kids. Eye contact as well gives us a little idea if for patients who are bipolar and during a manic episode, for their general behavior, there might be a lot of agitation. If there's anxiety, there could be a lot of agitation as well. For the eye contact, sometimes patients with schizophrenia who are actively in a having active visual hallucinations might be shifting their eyes, and you can document that eye contact was poor, evasive, and staring on to the side to the wall, kind of indicating that the patient might be having active visual hallucinations. Even if the patient, for example, was saying that they weren't having any auditory or visual hallucinations, but they kept shifting their eyes, that's a time where the subjective might not match the objective, and this is why these clinical findings are important, and to see what we need to do next, whether that be placing them on a hold, or whether that be increasing medication, or whether that just be watching the patient. Speech, another thing, if patients are catatonic, they might not be talking. If patients are in a manic episode, they might be hyperverbal, it might be uncontrolled. So documenting their speech gives a little bit more idea as well. So prosody is, is it the rhythm almost, is how I like to think about it, is like the rhythm of how they're talking. Are they talking like this? Or is there a specific rhythm or cadence to their speech? Latency is how long does it take for them to respond to your questions? Or is there almost like a delay, as if you're, calling someone from a different country before they start talking? And mood, this is just a quote from the patient. So when we go to do our intake, we always ask, how are you doing today? And they can say, I'm doing great, I'm doing bad, whatever that is. It's just a quote from the patient to include. Then we have affect. So affect is going to be, how their emotional state is. So there's the interview guide that I showed you before. This actually has a glossary of terms for everything that we're talking about. They also have the mini mental exam, and then also different examples of affect and things like that. But how does their emotional state during the examination look like? So congruent means they're saying they're sad, they look sad. Incongruent means they are talking about something depressing, or they are saying something sad, but they don't look really as well. And then we have the type. This is really important as well. Are they over the moon, euphoric, or are they really, really, solemn and sad and depressed, that's melancholic, and somewhere in between is, there as well. Quality and range. This is going from most, the most decreased emotion is flat, most intense emotion is going to be intense, and then it falls in between. I would say flat, it's really hard to say, and I'm still working on this myself, honestly, but flat is almost like, I usually see flat with like catatonic patients. It almost feels like you're not talking to a person. It's like you're talking to an inanimate object. Blunted is their emotions are diminished. Constricted is they can have the severity of an emotion like anger, but they're constricted to that one emotion. There's no movement from that one emotion. And is it an appropriate emotion or inappropriate emotion, right? Okay. Thought process. This is what I like to go backwards. So thought content is what they're thinking of. Thought process is how it's being verbalized. So thought process is it linear? Is it coherent? Are they continuously talking about the one thing, even if you ask different questions? That's perservative. Are they circumstantial and tangential kind of get confused often. Circumstantial is more like, do you ask them a question and they start somewhere and go around but end up answering the question, versus tangential is, do you ask a question, they answer some answers, but it's going totally off track. They're not really answering the question. Those are the differences between circumstantial and tangential. Flight of ideas is something you're going to see in mania. Thought content, this is really important. So are they having active plans of hurting themselves? Do they have a means of intent of hurting themselves? Or is it passive? Is it like, well, I've kind of thought about it, it's crossed my mind, but not really? Same with homicidal ideations. Are they currently experiencing any delusions or obsessions? So are they paranoid? Are they having any persecutory that, their delusions or people want to hurt them? Perceptions is specifically talking about hallucinations, depersonalizations. Always make sure, I always forget this, honestly, but it's really important, olfactory and gustatory hallucinations. Ask them about that. Are they feeling or tasting something, or smelling something that they shouldn't be smelling? Okay, now this bottom part here is the really important part. Everything here is important, but this is what is something that I learned to kind of tell us, what to proceed next with the patient. Insight. Insight is, do they understand their insight to their mental illness? Meaning, do they know that they have a mental illness, or they're experiencing something that seems like a hallucination? Are they aware of it? So, for example, a patient who's having the first episode of schizophrenia might not have insight and be like, no, what I'm experiencing is normal, or what I'm experiencing isn't a hallucination. This is actually what's happening. What I'm experiencing is a delusion is actually true. Versus someone who's maybe had medication management for schizophrenia and understands their diagnosis might say, I'm experiencing these. I know it's not true, but it's still bothering me, right? The difference in insight there and reality testing is what we call it, is going to tell us a difference of where the patient's at. So insight is super important. Judgment about the illness. So they might know that they have the illness, they might understand the severity, but they might not want to do anything about it, even though they're, for example, I've had patients who are walking on the street naked and they're like, well, that's fine. I know that I have this condition. I know it's probably causing this, but that's not good judgment, right? It's a threatening their safety. So that's why judgment is super important too. Do they understand and can they make, sound decisions with their mental illness? Impulse control. We see this a lot with kids. Sometimes there's multiple different reasons for self-injury. And that's a conversation for, a topic for another day. But are they able to control their impulses when there's a stressor in their life? Do they just go to self-injurious behaviors, or do they realize like, no, this is what's going on and I don't do that? Or do they say like, I thought about it, but I didn't do it? That's impulse control. And then cognition. This is really good for things like EDCL, but just seeing, and then all these concentration and memories. Are they oriented to person, place, or time and situation? Are they able to, is their memory good? Are we looking at something like delirium or dementia? This is where cognition becomes really important as well. And that is MSE. Again, this is something that you're going to be writing in your soap notes, but something that while you're doing your intake should keep in the back of your mind, because when you see the patient, you should be making sure to hit all these things and looking at all these things, because it just gives a better clinical picture of what's going on. And yeah, I hope this video, it should be shorter and give you an idea of the MSE. And then next, maybe I'll talk about some tips and tricks on how to do well on your rotations just in general.